Okay, it's 12 o'clock, so I'm going to start up and finish. This is your last 2 hours. So let's talk about aortic aneurysms. So I've mentioned them here and there along the line. What are they? These are outpouchings of an artery, of a vessel. In our case, predominantly what we're talking about is aorta. And it's an outpouching, and it causes a lot of problems. Whether some people have had them for years, they have what they call stable aneurysms. They never knew they had them, and then they'll have some scan for something. Maybe they have a kidney stone or something, and they put them under some helical scan, or they're doing something, abdominal scan for something, and they're like, do you realize you have this aortic aneurysm? So if they find them serendipitously like that, it's good because we can treat them easier than if they're acute. So what do we know? More men than women. We don't know why that is. Obviously, it's not the hormonal flux. More Caucasian than African American. So it's not necessarily just the disease, coronary artery disease, or people that don't have good vascular integrity. These people don't have good vascular integrity, but when you look at African American as a population, as a demographic group, they tend to have high hypertension, things like that. That's not quite relating here. That's not solely the issue. You have to have collagen issues as well. You have to have a breakdown in the wall. So it's more frequent with age, which is common with a lot of things, and it can occur in more than one location. And if it's, either side of the diaphragm is not a good thing either, because then you have them spread around the body. So you can have them in the periphery. They're not near as dangerous, obviously, as they are in your aortic trunk. Your aorta is your biggest artery in the body. So what do we know? Well, when they occur in the chest cavity, we call them thoracic. So anything above the diaphragm. These are probably a quarter of, Lewis estimates, a quarter of the aneurysms. By far, you will see more that are called triple A's. They're abdominal aortic aneurysms. And they're by far the majority of what you see. Most of them happen at or below the renal arteries, and that it's a very common site for them if they're abdominal aortic aneurysms. But the problem is, if they go in to do an open repair, as we'll talk about, they have to clamp above and below the aneurysm, and that means clamping off the renal artery supply. So that has big impact on your patients. The larger the aneurysm, obviously, the greater risk of rupture. The volume and the pressure inside your aorta is intense. So if that wall blows open, you just exsanguinate everywhere. There's not much we can do to lighten this topic. I tell students, I did actually find not a cartoon, it's not funny, but it's a little graphic, and it said, in one sketch, in one screen, it's a little black and white sketch of people talking on the street, and it says they're humanist, talk on the sidewalk. And the next frame is aneurysm, and the guy is lying dead on the sidewalk, and they say aneurysm die on the sidewalk. They drop dead on the sidewalk. So there's nothing good to be said about them. There's no humor to be found. It's a very quick death usually in people that rupture, but it's a devastating thing. So the primary causes, we know that there's degeneration. There has to be some degenerative component here. We know it can be congenital. If you have a congenital collagen disorder, that can be the issue. So they've tied it to that. It can be mechanical. It can be that there's been a penetrating trauma, like we're up in your heart doing something, like when I was telling you about the IABP, they're putting it up your aorta in reverse, they're swimming upstream, the blood goes the other way, and they're swimming upstream in someone who has some vascular compromise to begin with. We're taking this good sized balloon and trying to fish it up there. We can dislodge plaque, we can send, cut the wall, we can do anything like that. So it can be mechanical that way. It can be blunt trauma. Someone who's in a horrible car accident and gets pushed up against the steering wheel and they're pinned there. Somebody who gets hit in the chest with a baseball bat. Somebody who, falls a great distance and lands on their chest. Something like that. The shear that causes vessels and organs. You can have bleeds in other organs from injuries like that too. But the shear that it causes can tear a wall in the vessel. So we're looking at all of that. Inflammatory conditions are related to other diseases. HIV, you have an inflammatory process without an immune system. You know all the problems you get, all the opportunistic infections. Chlamydia is another one. So the patients can get aortitis from that. If you get an inflammatory process specifically to your aorta, it's going to put you at risk. It's an inflammatory state. Takayasu is an aortitis that a doctor noted in Japanese women, specifically in their eyes. So they would find them there and realize that it extrapolated to the fact that most of these women had aortic aneurysms as well. It's you don't see it often, obviously, with our demographic mix. All right, so the risk factors. We know it's men, so we're going to say male as a gender. Tobacco use, because tobacco is not good on any vasculature anywhere in the body. Excess weight doesn't help. Not a direct correlation, but it seems to be that the preponderance of people, not everybody, I've had very thin aneurysmic patients, but a preponderance of people, I guess study-wise, are heavy. Hypertension doesn't help. Any of the peripheral vascular, cardiovascular disease, whatever you have, high cholesterol, it's going to give you atheromatous plaque that puts your vessels at risk anyway. History of stroke, because it usually happens in people that are hypertensive and have vascular disease. You know, family history, there may be a genetic component that people just aren't picking up on. And they'll say, I don't know if I have any disease. Well, have you ever heard of an aneurysm? Yes, my father, my grandfather, my uncle died of them. Well, there's some kind of familial something here, you know, so they go looking for that. So what do we know about the genetic condition? We know that some people have these, you can be born with something, you know, a congenital thing that gives you, just like you have coarctation of the aorta and you have all these other anomalies, you could have something that affects your aorta in this way also. You could have valvular disease that you're born with, and the fact that it involves the tissues in your valve is enough to extrapolate out what else is it involving in the heart. Usually when there's one anomaly, we see others. People that are born with collagen disorders, like I tell you about Ehlers-Danlos, that's one that involves collagen regeneration and degradation. What's another one? Louis Dietz is another one. You know, if you work at big medical centers, you'll see these unusual cases come in. Marfan's, that's another one. It's genetically screened in people now, but that's another one. If people have that, we go looking for aneurysms. So they've also found a correlation with people who have polycystic kidney disease and things like that, that they tend to have issues in other organs, which is not surprising. And one of the areas they see is aneurysms in the aorta. So bad enough you have the polycystic disease, but you know, now we know there's other things you can have. Turner syndrome is a very rare, it's like they have web-like necks and they have, we see these aortic issues with Turner's more in women than in men, but it's just another case, you know, this is why patient history matters to physicians. They need to make these connections. All right, so what do we look at? Any aortic diameter greater than 3 centimeters is considered aneurysmic. Now, it's not often you're going to find somebody whose complete aorta is 3 centimeters. That's why they use that as a breaking mark. But what we see when we're looking for it is there's a bulge. There's a definite noticeable enlargement in one section of the aorta. It's the largest one. I told you the pressure is huge. So when it blows, it blows. That dilated area becomes dangerous because it can collect, if they're also somebody who has a lot of plaque and things, it can collect thrombi in there. And then they're at greater risk for stroke on top of their aneurysm. All right, so here's an example of an ascending and a descending. This is not the same patient. There would not be room in this chest cavity for these two aneurysms. This is just showing you an A aneurysm, as they refer to it in medical documentation, is if it's on the ascending side of the aorta. So it's over here. Here's your connections, your brachiocephalic and your carotid and subclavian. And then down here is if it's B. If it's descending, it'll be on the other side. So this is not the same patient, dear God. Bad enough they have one, never mind two. Okay, so here's a good depiction of a typical AAA. So they don't show you any collateral circulation here, but here's your heart. And then coming down here, you see these little branches here on the vein. and these branches on the aorta. There's more than that, and they're quite frequent, and they're offshoots all over the place. So you have a lot more circulation going to tissue and mesentery and colon and pancreas, and it's going off in all different directions. It's not, this is the main travel source, like the main highway, but not all the side streets. So this is a typical place. It's usually right above the bifurcation going to the legs by the iliac arteries. And so when they have to do this kind of a surgery, if they have to do an open case, it makes sense they would impact renal function. They will open this belly. This is retroperitoneal. This is all the way back down by the spine. And they have to clamp off above here, and they have to clamp below the aneurysm. So they're cutting off circulation to your kidneys except for whatever collateral little vessels you have that you would have normally, all these little offshoots that then have offspring, and they're all over the place. So all those little side streets is all you have going here. So if your patient is at all tenuous prior to this, that they have a little iffy kidney function, maybe a little, renal insufficiency or something, someone who's had to take NSAIDs for a real long time or something, and now they have this, they'll go in, if they do that open surgery, you are clamped above and below. Similarly, if you're clamped down here, what kind of circulation are you relying to in your lower extremities? So think of this concept, what we're talking about when we talk about this open surgery. We are clamping it so we can operate on it and clean it out, but we're clamping blood pressure, blood supply above and below except for collateral circulation. So that's what we're going to see in problems in these people after surgery. Okay. So here's your classifications. A true aneurysm is formed by the artery, and it's one layer that is intact. So we're looking at a fusiform here. The fusiform is uniform all the way around. It's completely around. It looks like a little stick figure with a pot belly. It's like all the way around. And again, it's right above the bifurcation. So it's all the way around, it's circumferential. The saccular one is pouch-like. So you have one layer is intact. There's one layer between your vessel and the rest of the peritoneal space. You're just one arterial wall away from breaking open. So that's a true aneurysm. A false one, or a pseudoaneurysm, there's rupture of all layers, but it's contained by, the bleeding is contained by structures, so it heals over. So this is like, we tend to see pseudoaneurysms at fistula sites, AV fistula sites, if you've ever worked with that population. So they're taking your artery and your vein, and they're connecting it with a conduit, right, to do your dialysis. So they're sewing into that artery. So many times they'll have a pseudoaneurysm. They'll find that doing that disruption, cutting that vessel, putting this foreign tube in there, and sewing it back up, has created now this false pocket. So it's a bubble because all the layers didn't heal up, but the outside layer is keeping it intact. The compression and everything else that's healed up has kept it intact. So they'll say when they're assessing a fistula, they'll say noted, right radial aneurysm, peripheral aneurysm. And it's called a pseudoaneurysm because it's not really caused by the same degradation that normally causes aneurysms to happen. Okay, so what do you see? Well, thoracic aneurysms are often asymptomatic. People walk around, don't even know they have them until they get to big enough space where there's no room for them in the thorax, and then they're painfully aware of them. So they're typically, and these people drop dead typically when they rupture. So I knew a guy who delivered my first child, an obstetrician, big hulky guy, and he was sitting at his breakfast table and tipped over on his 8-year-old. He had a spoon in his hand, he was eating cereal and tipped over. And he was dead from a thoracic aneurysm. So all that time he was working, never knew he had it. He was only 40, never knew he had it. So is he somebody that had it his whole life and no one knew it was there because he never got scanned for anything, but he was dead in a flash, So usually they're asymptomatic and then they can blow and the person never knows what's hit them. When they're symptomatic, they have this deep diffuse chest pain. So they're going to present to you in the ED and you're thinking, okay, this is my MI. because that's, I mean, it's just deep and they're holding their chest and they're trying to breathe and you're thinking, I don't know, let's do some workup, do some assessment and see what we're looking at here. Could be an MI, could be an aneurysm. So they do have inguinal pain. That's the other problem here. Because if the aneurysm is getting wider and wider, we don't know what it's compressing in there. We don't know how it's, dilating that vessel and disturbing the normal flow of blood. Are they getting a normal amount into the ostia? We don't know. If they're not, they're going to have inguinal pain. So there could be some inguinal pain. So they might give them a nitro and they may feel a little bit better after it, but they still have this deep underlying pain. So they can have TIAs. As this vessel, if you have plaque in a vessel and it starts distending and getting stretched and stretched, as those walls go out, that plaque loosens. That plaque was fixed on a vessel that was maybe this wide all the way around. And now it's gotten bigger and bigger, that plaque loosens and shoots off. And sometimes the only way we find the aneurysm is they've already stroked and we're treating them for stroke and we just happen to scan them and see that there's an aneurysm. And they say, okay, chicken or the egg here. It's most likely the aneurysm caused the plaque to go. And it's so close to those vessels on your aorta, it's going to send plaque right up to your brain. So that can happen. Sometimes they're just have that horsey, cough, throaty kind of, and they might send them to ENT if that brings them into the doctor. Do I have some? I don't feel sick. I don't feel a cold. What is this? I have this constant, and they'll check you out. Sometimes they send you ENT. I know a patient a year ago we had that they sent them to an allergist, and the allergist gave them all kinds of stuff, and he was taking it and nothing helped. And then he started feeling this diffuse pain. So he comes in with this long history and everyone's looking saying, oh, now we see. All he had was this hoarse coughing. That was it. And, that's a problem. Sometimes I've had people complain of dysphagia. So they go to the doctor, they have a GI workup. And in the process of the GI workup, they're like, nah, I don't think so. I think you have an aneurysm. And the person's thinking, oh, they're going to scope me like everybody else. No. And the pressure you're feeling on your esophagus is this dilated part of your aorta. So it can be a number of things. You can have a patient with JVD. So think of the things you've learned about it. But what's the concept of JVD? When blood can't flow where it's supposed to and it backs up, we're going to see it. We're going to see it in vessels. So here you have compression now in the thorax, and that makes it harder for the blood to be functioning. I mean, you get this big dilated, ascending aneurysm, there's pressure effects. And all of a sudden we start seeing this patient with JVD. Doesn't have to be a tension, doesn't have to be tamponade, can be, doesn't have to be. So with that, they tend to get edema of the neck and the face. And the only way we see this is if they've had it for a while and have been otherwise asymptomatic. They don't notice JVD. And if they're not having that crushing, deep, diffuse chest pain and it's not bringing them in, they might have the dysphagia. And so they've been eating Tums and Rolaids and whatever they have, but that's not doing it. So the underlying cause, we have to go a little bit deeper. Okay, so what else? What do you see? Abdominal aortic aneurysms are really often asymptomatic. They're typically found on routine exams. They can be just a pulsatile mass left of the abdomen. Now, if you're a thin person, don't lay down on your bed and say, I feel a pulsatile mass. You will feel your aorta if you're thin, but you don't feel the mass of an aorta. It's different. And we don't go palpating when we know somebody has one. So I can't tell you next time you're on a unit and someone says someone has abdominal aortic aneurysm and they have this pulsatile mass, don't go in palpating it to see. You'll have to look at film and whatnot because we don't go pressing it for fear it rupture. But a bruit is audible. Now we've talked about bruits before, right? Thyroids, when they're really vascular, have a bruit. Your carotid can have a bruit if you have coronary artery disease. You have a bruit in your fistula. It's noise. It's a French word for noise. So here, you can have a bruit inside this pulsatile mass in your abdomen. So more often, it's vague complaints. just low back pain, you're stretching it and moving around. Other people can tell you're a little uncomfortable. It's not the kind to keep you in bed all day. It's a vague kind of chest pain. And patients say to me, I tried heating pads, they tried Tylenol, they tried Advil, they went to a chiropractor. I mean, it's been a nagging kind of a low back pain. Nothing so acute that they need to be in the ED. They might have epigastric complaints. They might have bowel complaints. So bowels aren't regulated. What are people going to do? They're going to start taking something, Metamucil or Miralax or Dulcolax or something, right? So they can handle those complaints at home. They're not thinking, oh, this pressure and this is low down. This must be referred from a AAA. People don't know what that is. So that's not where they're thinking. They can have intermittent claudication. You learned about this in one of your classes with vascular disease in the leg, peripheral vascular disease. So, people get up and they can walk maybe a block and then their legs hurt. They have pain in their legs. They have to sit down. And after a few minutes, they can get up and they can walk again. They do okay until they have to sit down again. So it's pretty classic of intermittent claudication. So they go and work them up. It could be their femoral arteries have blockage. It could be their iliac arteries have blockage. It could be they have an abdominal aortic aneurysm. So that's an issue. Also, the patients can have blue toe syndrome. Not all of them with AAAs have it, but it's pretty common. And so what you're finding here, you'll notice it because you're going to assess people. Remember, I told you when you're doing your foot assessment, take the socks off. So not only are we looking for, all the spots on the foot, the Janeways and all that, aside from that, we're looking to see for blue toe syndrome. This is, you have speckly blue areas. You have a pulse in the foot, but you're looking around the toe and these little splotchy, speckly areas. And it's from these little microclots that come off. And it's a key to someone having a AAA. So it's something you should take note of. All right, so what are the complications? The big one is rupture, because it ruptures and you're dead. I mean, there's instant hypovolemia in your system. This is your main highway and it's gone. I mean, think of any highway we have. If it went down in the middle, everything stops, right? No traffic can get through, nothing. So this blood just goes everywhere and you just die of shock. You're instantly hypotensive. In the abdomen, if we know you have one, let's say you came in for a kidney stone or something, they scanned you, they see it. Now they know you have it. Well, now they don't know how long you had it. Is it an operative size? Let's watch it a little. They might do that, put you on some meds, try and control your blood pressure, that kind of thing, and keep scanning you and watch it and see what happens. You could have been born with it for all we know. My husband's uncle, before he started on chemotherapy, they did a scan. They were doing body scans to see the mets he had. And they found he had a carotid aneurysm and he had an abdominal aortic aneurysm. So of course, Pat's aunt calls me up with this heavy accent and she says, I'll spell for you what they said your uncle has. I said, okay. She says, ABDOM, okay, abdominal. And then she's like, AORT. I'm like, oh God, he's got a AAA. So I said, well, what are they saying about it? And she said, then it says -stable. And I'm like, okay, because if it's not stable, they won't do chemo. And then he'd really be cooked. So, but then they watched it all through his chemo to make sure it didn't change. And in the end, they decided he was born with both of them. He went through multiple surgeries. He went all through chemo. Nothing ever happened to it. They never grew a inch in size. They monitored it for 3 years, nothing. So he was probably just born with that. But how would you know? I mean, we're not in there to see what we have, right? So, somebody that if we know you have it, then we're alerted. So let's say we knew Uncle Frank had those and he presents to the ED and he's got these vague back complaints and he's got this pressure down his legs and all of these things. All of a sudden they're looking and saying, look in his history, he's got this AAA. And they'll go looking for that. If we know you have one and you start presenting with symptoms of it, we'll get you upstairs to the OR and see if we can't fix it, get all the way in there and get you going before it blows. Because when it blows, you're a lot worse off. You're typically dead. So Gray-Turner syndrome we look for. This is something you've learned about with what? Well, I should be asking you. What have you learned about with Gray-Turner syndrome? think back, multiple things. Oh, hemorrhagic pancreatitis. So someone has acute or chronic, for that matter, pancreatitis, and with a repetitive bout, it becomes hemorrhagic. You have this bruising all along your flank. You look at someone's back and they'll have bruising. You have it with certain parts of liver disease in the end stage. You can have it with several things, but it's reflective of hemorrhaging that it shows more on the backside. And remember, we are retroperitoneal here. We are all the way back against the spine. So you're going to see that. Takes, what, 12, 24 hours for you to have a hematoma, so it doesn't show right away, but it's something you're watching for. They'll have a low BP if it's seeping, and we're wondering, where is the blood going? And the heart rate's going up, and that should be your indicator that something's off here. When the blood pressure drops enough, those neuroendocrines are going to kick out that we learned about in adrenal, and we've seen with everything cardiac. And what's the response now? You're going to have the elevated heart rate, you get clammy and diaphoretic, they have altered mental status from the drop in BP, that the blood isn't getting up the aortic arch. They have pain, growing pain in their legs and their back. They have decreased urine output when the kidneys are not perfusing. So we start to put this other picture together and we're thinking, okay, Uncle Frank has to get to the OR because he's seeping blood somewhere. Let's see if we get in there and fix that aneurysm. Now, if they go in to fix an aneurysm that they know to be stable and they want to fix it electively, and they get you in the OR, and while they go to work on you, it blows, they have a pretty good chance of saving your life because they're in there already. The problem is you start to bleed, they have to get you up to an OR, get your case going, get you open, even get to the spot, and you're gushing blood the whole time. It's just really, I mean, the mortality is so high with aneurysms. So they might survive. Think of the organ impairment. If you have not perfused your kidneys, or they have to open you and do an open repair, and they've clamped you above and below, the surgery can take multiple hours. By the time they get in there and move everything, you know, they're manipulating organs, getting you in there. And then to do the surgery, the time you're clamped is probably an hour at least of the surgery. But in that time, you're relying on collateral circulation, that if you've been seeping blood, and that's why they rushed you in, you have a decreased blood pressure to begin with. So it's really hard to manage them and hope that collateral is enough to keep your bowels functioning, your mesentery, you know, full of blood, with enough blood to support your bowels, to keep your kidneys going, all of that. So many is the patient I've had that has had a AAA and wakes up from anesthesia and has to face dialysis the rest of their life. The kidneys are most sensitive to that. Sometimes they'll stroke in surgery and we won't know it until we can't regain them afterwards. And then we go scanning ahead to see. But that plaque that dissipates, I mean, we only have so much control over it. So in the hospital, they estimate mortality rate to be about 53%, which seems low for aneurysmic patients, but people in the hospital sometimes are there electively to have it repaired before it blows. So that accounts for the people that survive. Okay. Other people are like, no, if I don't need the surgery right this minute, I'm not doing it. And that's their choice, right? That's their choice. Okay, so diagnostically, what do? A CT is the most accurate assessment. CTs tell us everything. Not much can hide behind them. So it tells us the length and the diameter. And if we do serial CTs, if they did one 6 months ago when they found it and they did it 2 months later, they can see if it's grown at all. So it really gives them a good view. For chest x-rays, they can do, if you have a thoracic one, it's going to show a widening in the shadow. It's not, you know, abdominally, sometimes the radiologist will say, I see a calcific edge all along the end. It's not as good as having a CT that's going to give us a good shot of it. They'll do EKGs with someone presenting because they're trying to rule out an MI, which you could have an MI on top of your aneurysm. I've had those too, and not me, but the people I've taken care of. So it further complicates what you're trying to do for this patient to keep them stable. So ultrasounds, they can do them. They can monitor the size of them, but remember, we don't want to push anything over a pulsatile mass in the abdomen. So they might be doing echoes to try and see a thoracic one, if that's what's close by and they can do a quick check. But I've seen people resist doing the ultrasounds to the abdomen because they have to push the probe against your belly. And you know, they don't want to put any pressure on it. Okay, so cardiac echo, I told you. MRIs can help with location severity because it's going to, the imaging is a little different than the CAT scan. So angiography, they often do. In fact, I've had patients that go and they have to have a cardiac cath before they have the surgery electively to repair their aneurysm, because if they have blocked vessels in the heart, in the coronary circulation, they'll have them fix that first and then do the aneurysm. And we're thinking, yikes, you're going to take these people into a cabbage that have this aneurysm that with any flux of BP, and you know, they induce people with anesthesia, their pressures go up and down. There's plenty of times your heart rate will go up and down having surgery. This patient will be on bypass, but they want them to do that first because they don't think they'll survive it the other way. So you got to hope they survive the cabbage in order to come back and have the elective surgery on the aneurysm. Okay, interprofessional care. Well, we want to manage someone who has it and avoid the rupture, God knows. So early detection is important. And as I say, most time it's serendipitous. You know, you come in, you have a bad belly, and they scan you to see if you have diverticuli or something. And they're like, no, you don't have diverticuli, but you do have this AAA. So they find it that way. The medical management is acceptable if it's less than 5 centimeters and if we can control your BP. If you are a malignantly hypertensive person, that they're putting you on nipride when you come in with these episodes, no, they've got to get this blood pressure under control. Because you could blow now, you could blow in surgery, you could, I mean, it's just, we can't take you in that kind of a state. So they're going to control the BP, they're going to get you on an anti-cholesterol management, get you on statins for a while, get you to quit smoking. God knows, quit smoking. There is nothing good that smoking does to the body that we don't need to get rid of it. Hopefully prior to a disease state, but in this case, it would just be adding insult to injury. So they're going to keep monitoring you, however they do that. They want to scan you or do MRIs, whatever they want to do. So beta blockers are helpful. They're going to lower your heart rate, lower your blood pressure. That's always a go-to drug they like. It helps a little bit with dilation. It's good. Statins, of course, you're on. And then doxycycline. So here we come with this other drug that's like, okay, so what is doxycycline? This is vibramycin. This is a tetracycline antibiotic. This patient is not infected. Once more, we're using it for something else we know about the drug. And the patient will say to you, if you go in and say, I have this here, I have your beta blocker, I have your antibiotic, I don't need an antibiotic. You know, be careful what you say to patients. So the reason they're on doxycycline is one of the side effects of this antibiotic, and it's a good antibiotic, we don't mind it, but one of the things we know it does is interfere with MMPs, that's matrix metalloproteinases. You don't need to know the pharmacological stuff and all at this point, but doxycycline is something you'll see used on these people, so that part you should know. But anyway, there is a reason why we use it. And so why do we care if it interferes with MMPs? Well, this matrix metalloproteinase is what helps with degradation of the lining of the vessels. And there's a normal process for that. It's not that we don't want to have MMPs. We have them. We don't mind them. They serve their purpose as cell renewal and all of that. But this inhibits that. And in this patient who already has an issue with their collagen or the construct of this vessel that is wearing down because they have collagen disease or whatever their problem, they have, you know, artery disease, aortitis, whatever they have, we could at least stop the MMPs from doing its thing. So they'll put them on doxycycline to interfere with that MMP coming out and helping to break down the blood vessel. So that's why. Surgical management. So we do an open repair and put a graft in there. And a lot of them have open repairs. Yes, we can do a minimally invasive one. It's not for everybody. Not everybody's a candidate. So with the open one, they're going to clamp you above and below the aneurysm, which is typically around your renal arteries. And they're going to open it up and clean it out and put the graft in and sew the native wall back on. So I know I have some good videos here. I tried them all through lunch 3 or 4 times, 3 or 4 different ways. I can't get them to come up. So at least you have the links here if you get a chance and you want to watch them. But surgical repair is a treatment of choice. If you're asymptomatic and we know you have a genetic disorder, and maybe your father dropped out of an aneurysm, God forbid, somebody in your family that we're thinking, eh, or you start to become symptomatic and the doctor will say, look, your risk of dying suddenly from an aneurysm is pretty good. You want to go in and have this surgery before this happens. And so people will come in electively. So medical review is important. They're going to look at everything. Let's look at your kidney function because we know they're going to go in and clamp your blood supply for a while. And you got to survive. Your kidney's got to survive on collaterals. So if they have the carotid blockage, they're going to make them do the CABGs first, whatever they have to do to fix that. We're going to get you well hydrated because we don't want a drop. We don't want you hypertensive, but we don't want a drop in your BP either. And get your electrolytes, get your hemoglobin where it needs to be, optimize you before you go in and have this done. Okay, so here's basically, this is a good picture too, but here's basically your aorta here. Looks pretty skinny, but here it is. And here's your bifurcation down here where it goes down your legs. And so your kidneys are off here, this offshoot. So they're gonna go in, they clamp above and below, and they're gonna cut the native wall. That's this thing here, this big thing that's getting sewed on. They're gonna cut the native wall open. They clean out all the clots and all the plaque and everything that's in there. They take this graft right here. Do I have one? Amongst my toys, I have them someplace. They're looking rather ratty after all this time, but they're here. So they put the graft in like so. These, they come all bunched up like this, and they open up like accordions like this. So they put the graft in, and they're Dacron, they're all different materials. Here's one that goes down the legs that, you know, if you have to go down the bifurcation. So they're gonna cut this open and clean it all out, and then they put this graft in and they sew it all along the bottom, all the way around. So think of the anastomotic site here that is potential of leaking. Under this piece up here, they've sewn it in all over here, all around. And then they close this native wall around it and sew it up. And the thinking is now the blood will come down through this graft that's in here and go on its way. And everything should be good. I don't know, we'll see what complications we have. Okay, the other thing we can do is endovascular. Endovascular is the one people are always saying, yeah, that would be me, let's do that one so you don't have to open my belly. Because when they open it for AAA, you're pretty much split from xiphoid to pubis. I mean, it's a pretty big incision. So they'll say, yes, I would like that. Minimally invasive one would be better. So the good thing is it's minimally invasive, and it's a good thing. And it's sutureless. We go in through the groin. We go up to where the aneurysm is. They can use these same type of grafts. They put them in, they tack them with a stent. I'll show you in a minute. And they take it down. And if it's got to go down your legs, they track it down your leg a little, you know, into your femoral arteries. And they seal it up, they tack it to the walls. And, you know, they think everything is going to be good then. They come back out and they seal up your groin incision. Now, it's definitely less invasive. It's definitely smaller incisions, easier recovery for the patients, less anesthesia, less manipulation of everything. But really, over time, the mortality is no different. And why is that? Because if somebody has a predisposition to one aneurysm, they could have others. And if you have vascular disease to begin with, while we repair this one little area to minimize your risk of death, it doesn't straighten out your vascular disease everywhere else that we might not know of. You know, you could have the aneurysm like Pat's uncle up in your head that we don't even know, in your carotid. So, you know, it doesn't, over time, it's not the answer to all things. So what are the risks here? Well, you can have an endo leak. I showed you all those anastomotic sites. Any one of those can leak. Plus the fact they anticoag your patient because we're impressing these grafts. We're stitching them in when we do the open case. We're sticking them into the vessels so they adhere to the wall in the EVAR. So we can disrupt plaque. And if we disrupt plaque as it floats around, your body's saying foreign substance, send the fibrinogen, send this, send that. Everything goes to it, and you make a bigger embolus. So this patient is anti-coagulant and all too. So, you know, endo leaks are certainly possible. The migration of the graft, this can migrate, can come undone and just migrate and be moving. Not a good thing. Now you have open sites, your patient's bleeding so fast, you don't know what's happening to them. We can't see inside. We have to fly by our antenna. So you could also have aneurysmic growth above or below. So we've repaired the one by your kidneys, and now 6 months later, they scan you to see how you're doing, and you have a bigger one above. Because what the underlying cause is, we can't get after. If you've been a smoker for years, if you're part of that male demographic group that smokes, if on top of that you have some collagen issue, you know, think of all the things that impact this. So even if they have an EVAR, sometimes they need an open repair. They'll say, no, we tried the EVAR once, it didn't work well. Let's go to the open. Okay, so here's your EVAR. So they do a femoral cut down, and they're gonna go in one side with this Dacron cylinder, this little thing, and a flexible wire on the inside. And they put it up on the inside of this gauze, really. It's a little stronger than gauze, this Dacron. And they put it up, and they can contour it to go around your vessels. A good thing here is you can see how they'd have to be above and below the kidneys. But here, they don't have to clamp when they do the EVAR, because the blood is flowing right along them doing this. They're not clamping anything. It's minimally invasive. So they go up one groin, and they put it up, and they stick the edges along the top here, all in the vessel wall, all the way around. And then they pull this down. If they need to go down the leg a little, they do. If they have one that's not two-legged like this, they take another one and splice it, and put it up. So, and then they're done. And that's now your new area. This will over time just shrink away, this original aneurysm here. This is now considered, that's your channel for your aorta. And so it stays there, and we hope they do well. Most people do, but you know, there's always a risk, always. Okay, so, oh, that's a good video. We'll try and watch these videos. I tried them. I can't get them to open. IT doesn't know. I put a ticket. They don't know why. Okay, so what are our complications then? Well, aneurysm above or below the repair, always possible, always. A renal artery occlusion, yeah, definitely, because we have you clamped above and below your aneurysm, which is typically right in the middle of your renal arteries. An aortic dissection, yeah, because we're putting something inside your aortic vessel, and you already have an aneurysmic history. So as we're putting up with the EVAR, as we're putting up the catheters to get ready, as we're putting up the mesh grafts, as we're putting up the Dacron, and we're embedding it into your vessel wall. So are we, you know, letting go of plaque? Are we causing more? I mean, it could be anything. Anything could happen in there. And it's all within the confines right around your renal artery. So it can, you know, you can definitely nick the wall, have any kind of problem, and create yourself an aortic dissection. So that's not good. All we have to do is have one layer of the aorta open, catching blood that should be in the main aorta. And now we have blood diversion. So we have real cardiac output trouble. All right, so you can have an endo leak. So wherever we've done the anastomotic site, it's seeping blood. That's a problem. It's a problem in an open one. They can start bleeding from an EVAR. You can have an endo leak there too. So you can have a graft thrombosis. You can have that we have now put this foreign object in somebody, and a week later the body's saying, by the way, what's this foreign thing sitting in the aorta? Let's go get it. And they try and encapsulate it in the fibrin and everything else and try and wall it off like an abscess. And that can occlude, that can thrombose your graft. So that can be a problem. Infection. If we've done an open case, you're wide open and we're all the way down, it's an extensive surgery. Now you have this big long wound. If we've done an EVAR, we've gone in through the groin, filthy dirty, and we clean it all up and scrub it down and shave the skin and all of that. It still has a risk of infection. And after the procedure, we have to keep that site clean so it doesn't get infected. So, you know, it can be anything that goes through the skin, carries bugs, so you got to be careful. Hematomas can happen. So they'll start weaning you down off of your anti-coags, and all of a sudden people are now clotting, and you can get a clot somewhere. So there's a lot of things that can happen. By and large, it works well, and a lot of people do well with it. It's a nice option to have the EVAR versus the OR, you know, the open aneurysmic repair, but it all depends on what the patient, what suits them the best, what they need. All right, so issues to consider. If someone survives a rupture, which they would probably have to be open in the OR when it ruptured, or at least if they come in bleeding, they're seeping. It's not an open blown thing, they're just seeping blood. Just think about the intra-abdominal hypertension that happens. They have an emergent repair then, so they go in for an open one. If you're an emergent case, you're going to the OR. So they open you up. They have this compartment syndrome. No one was prepared for this. Your bowels haven't been evac'd. Everything is being shut off from mesenteric supply and from, you know, your blood supply is really, you're relying on collateral circulation. So your bowels can be affected, your kidneys can be affected. You know, it's a real problem. So they usually need surgical intervention. If you start interfering with blood flow from more than one organ, you can be looking at a MOD situation. So the patients are very, very sick. I've never had really a case that is just, you had a AAA, oh good, everything's perfect, and out they go. Because they're comorbid, they have other problems that go on. So abdominal compartment syndrome is bad news, bad news. So we have done, there's catheters now, Foley catheters that measure intravesicular pressures. Excuse me, meaning inside, vesicular is like a, you know, a space inside the bladder. So they measure pressures in there, which indirectly tell us the pressures in the abdomen. And those patients will have these Foleys so that we can measure intra-abdominal pressure to see if this patient has compartment syndrome of the abdomen. I dragged a whole bunch of students in one time. The physicians weren't great about it. I had them looking through windows around this room because they were going to open somebody right by the bedside, open the belly. And they had been rounding and it hit them. This is what's happening now. And they called for an OR table, you know, and they'll bring them down. It's not laminar flow. It's not the best of circumstances. We're not in a negative pressure room like in the OR. And they'll bring tables down with 10,000 drapes on them and run them in with all the equipment and put the big lights and do whatever. And they opened this guy's belly. I mean, just sliced it open. And it was like cords and cords of black loops. And of course, I knew they were going to open the belly by the bedside. So I'm collecting students wherever I can find them, and I have them on these step stools and everything. And one of them turned to me and she said, Jane, it's just black snakes. What happened? And I said, it's bowel. It's necrotic bowel from abdominal compartment syndrome. I mean, just loops of it. And they had to take it all out. It's necrotic tissue, but it's abdominal compartment syndrome. It was lacking blood supply, and the belly was getting more and more distended and more rigid, which is a sign of peritonitis. And they came in and they said, get us a set. There's no OR room. There's no time to get them there. Get us a set. We open the belly. And, you know, the students were all like, you know, not what they expected to see that day in clinical, but it gave them frame of reference to realize how sick these people can get, and pretty quick too. So mortality is high with ruptures and repairs. They're still not out of the woods if they've had a repair. Okay, it's 10 till. All right, take your break. I'll see you top of the hour. So let me address this. I have been anticipating every day getting the list from the hospital, and it is not coming yet. So where does this put us with orientation tomorrow? We still have orientation, and we'll still cover, believe me, there's a lot to cover in orientation. So we will go all through that. When we get out, we get out. So it likely will not go to 2. If she gives me the list overnight and I can miraculously get it done by the morning, then that'll be a different story. We'll be here till 2 anyway. But right now, what we use that last time period for is for all of you to break up into your individual clinical groups. So my group comes to me and we talk about expectations, and I answer all your questions, and anything you're worried about, Janie's group goes with Janie, Bridget's group goes with Bridget. So, you know, I don't know, unless I get a list in the next 24 hours, you know, you may have a little extra time tomorrow, but I can only go with, maybe it comes, you know, she didn't promise it would come today. She didn't promise it would come tomorrow. She said she's aiming for the weekend. So I don't know. I told her this is really putting us, you know, behind. So,
Hey,
Hey,
Jane.
Preceptorship meetings on Friday, right? Not tomorrow. Tomorrow's our sim.
I'm scaring you all to death on your last day. No, not tomorrow, not tomorrow. Friday. So she's telling me in the text I just read that she's hoping she can get it to me for the weekend. And I said to her, is there any prayer I can get it? And she said, there's a possibility. So if I get it in time, like if she sends it to me tomorrow and I can work on it tomorrow and have it for you on Friday, then we'll have the list and we'll be here as long as it takes us to get through everything. But if not, you may be getting out a little earlier. It's just too soon for me to know. And this process is nothing in the planning. It's totally out of our control. We are reliant on the nursing office. And until they give us a list, you know, but I imagine my weekend will be quite busy. So if I really get
Hey, Jane.
a situation, I reach out to people and I ask them about choices or whatever. But yes, who has a question?
Melissa, how do we know what clinical group we're in, whether you, Janie, or Miss Teben? Is it based off of the last names that we're already assigned to, or is it based off of where we go?
Based on the units and where you go. So
Okay.
Until I get the assignments and people are randomly assigned, I won't know who's going where. Yeah. I know it's a very unnerving process at this point because you're all anxiously awaiting, as are we, and it's a lot of work to get this huge spreadsheet together. So I would like it sooner rather than later, but you know, I'm impotent to control it at this point.
And one last question.
Sure.
If we, I know I asked Janie, I think a couple weeks ago, if she wanted us to like message her if we were okay with doing nights or like preferred nights or anything. Should we send you that information, or does it kind of just go up in the air?
No, it's, I don't know how many night spots we'll have. Typically, they want us evenly split, so they try and give us a third of the number for nights. And if that's the case, then, you know, people that already work nights, that have husbands that work days and they need to work nights, something like that, I try and accommodate that. If not enough people offer, you know, say, yes, I'll do a night, and I have more night slots than I have people going on it, I have to assign nights, because for 12 shifts, you have to get your time in. But I try and give it to the people who that fits their life. I mean, that's only, but otherwise it's completely random, because it's the only fair way we know to go. I mean, I can't, you know, pick someone where they want to go and not give that same choice to everybody else. So we'll see come Friday, but there's a lot of stuff to go over. So I don't know, let's see, let's hope the stars align and I get, you know, she's good at this and gets me a list. It makes everybody's life easier, you know? All right, so let me continue. Where were we? So issues to consider. I was telling you already that, you know, they'll have this intra-abdominal compartment syndrome, and that's a real problem for people. They end up with multiple organ dysfunction after that. Okay, so what do? You're going to assess your patient, because pre-op, if you have them, you want to know what the norms are, because likely this patient is coming back to you. If they're really in a tenuous spot, they'll have them in an ICU, even pre-op, if that's what they need to do. So they're monitored closely. You want baseline. How compliant are they with medical regimen? As you're admitting them, you want to know these things, because they have to be compliant post-op with post-op care. So do all the normal pre and post-op teaching. What can they expect? The length of time they'll be in recovery is usually equal to what they were in the OR. Then if they're coming to an ICU, sometimes it's less than that, because they know they can even send you not completely reversed, and we can do it in the OR, in the ICU. So what was the bowel prep? Did the doctors have them do a bowel prep, knowing this was anticipated, that this was elective correction? You know, is there skin prep done? All of that stuff at our hospital tends to be done in the OR by OR techs. They'll be NPO before surgery. They'll be NPO after surgery for a while. So that's important. Tell them about the IV lines they'll have, that they'll be on prophylactic antibiotics, that if they've been on beta blockers, they may still be on them afterwards. But typically, they do it to control the heart rate and blood pressure. What they don't want to have happen is that you coming out of anesthesia, whatever way your body feels, however restless you get, they don't want the beta receptor responses to get tripped and start giving you epinephrine, norepinephrine that's going to cause you issues. So they want to dull that beta response a little bit. Plus, it helps control your heart rate and your BP. We need enough of a BP to perfuse our graft. You know, we don't want them tanking really low, but we don't need them hypertensive either, not in a fresh surgical patient, because they'll blow their graft. So you have to be careful. You have to watch them closely. All right, so what do? Post-op, you're gonna assess them. You're all over this patient. You're married to them for several hours, just constantly in the room, there all the time. They're in an ICU bed, generally 48 hours, depending on the complications they have, it could be longer than that. Some of them come and just tend to lodge. You know, they need to be there a long time. They're on the cardiac monitor. They're vented initially. That means a lot of ABGs. You're in and out of the art line. So watch that art line that you're not contaminating it. They'll probably have a pulmonary artery catheter line, so you're dealing with that. If not, they're having CVP pressures measured to some extent, APCO or through a central line or with a swan, if they have a swan. Vital signs, pedal pulses. If this is a AAA we're talking, we have to, arteries carry blood away. The natural flow is to come from the heart downward. It's bringing blood to the extremities. This patient had that clocked off for a while, clamped off completely while that open surgery was being done. So you need to check those pedal pulses. What's our circulation like below the injury site, below the surgical site? NG tube for decompression. We don't need this patient vomiting. What that's going to do to abdominal pressure and tension on the wound, it's going to raise the pressure to begin with, increases risk of aspiration. So they have an NG tube to decompress. They'll have a Foley that most likely will be measuring intra-abdominal pressures for you. So you have to keep an eye on that too. Make sure they're not getting too high. Watch your IV lines. They might have this central line. Maybe it's not a swan, but they'll have a central line. So maybe they have a couple of peripherals. Peripherals are only good as the quality they are. If they're flushing well, if they're ready for you, that's good. Typically, they'll have central lines and multiple, you know, like a triple lumen or something. What else? Thoracic repairs. If we've done an open chest on this patient, they have chest tubes, the whole spiel like they have with any other chest surgery. Because we've cracked the chest to get in there and do this repair, you know, we've diverted their blood, we've popped the lung to be able to be in the chest, so they have chest tubes and the whole spiel. They're very, very sick people. They'll have epidural catheters for pain initially, and then from that, they'll be on a PCA, so they'll stop the epidural. They might be on a PCA for a day or two, and then from that, they'll go to PO coverage. The epidural catheters work great. It really minimizes a lot of this horrible pain they have with this surgery. So what are we worried about? An unstable BP. We're always worried about that. We've already had an artery that's probably been clamped off for quite a while in the abdominal aortic aneurysm. So what's happening now? We have to worry that if we're not getting, if for some reason this patient becomes hypotensive on you, you're not, again, perfusing the kidneys. You know, you got to think they probably are already at risk for kidneys. And now if the pressure drops, they're not perfusing the kidneys again if it goes below 80. So we got to watch that. Dysrhythmias, that can happen. They're not the most stable people in the world having these surgeries. And this is a big surgery. So depending on, you know, the state they're in, maybe you're focused on the aneurysm, but you can't lose sight of everything else. Embolisms are always a problem. Leaking at the sites, remember all that anastomosis and how far down it is in the body and how long it would take them to get back in there and do something about it. So you got to be watching for, you know, hemodynamic instability. That's how you see it. Migration of the graft, that happens whether it's an OAR or whether it's a EVAR. So renal dysfunction, infection is always there. especially your EVAR. Think of your groin. You got to keep it clean. And watch their neurostatus. Let's not forget, they might be doing great with their surgical area and they've stroked in surgery. And we won't know it till they reverse from anesthesia and we see they're not there, their neurosigns are off. So it's a whole nother deal, you know? Okay, systemic concerns, graft patency we talked about, neurofunction, cardiovascular, GI, every system can be impacted by this. The peripheral circulation, the kidneys, everything is affected by this. So you do your systemic assessments on your patient constantly, and you're watching for any kind of change. All right. What do we teach survivors? Gradual increase in activity. They're like, oh, it's done, then it's done, it's good, it's done. No, it's done. You've had a huge surgery, and we're watching you very carefully. So it's not like we're going to get them up and moving, but they're going to be fatigued for a long time. That fatigue, they go home, they're exhausted. They're still exhausted for a while. The body's been through a lot. It's been through a lot. So they'll have poor appetite. It's not just anesthesia, but think about it. I mean, they've had decreased circulation for a while, and we're hoping now they've got bowel sounds back. This is a good sign, but it really affects their appetite. So we can't have them not eating. So you're really going to have to push this patient to start eating their meals. We can start with things that that they crave, that they want to eat, as long as it's healthy food. You know, they want Kentucky Fried Chicken. No way, no way, Jose, that's not happening. So, you know, they can, what do you like to eat? What's your go-to food? And if it's something that's, you know, we can give them chicken and vegetables. We can, if that's what they have they like a certain way it's prepared, we can do that, but we can't give you Kentucky Fried Chicken. So we do what we can. Get nutrition involved. I get the dietitian up. That's a great resource. What can they give them? What flavors does he like? What do we have that appeals to this? Do they want more cold foods than hot? We can do that. Let's get you cold sandwich. We can do that. It's fresh sliced turkey they do from the cafeteria. We can do that. Custards are good. They're full of nutrition. Not for all day long, but here and there. It gives them calories. So they'll look for supplemental drinks and things they can get them, stuff that's palatable. We got to get them eating. Bowel irregularities are common, and no surprise to you, right? There's been diminished blood flow, and afterwards for their bowels to come around, sometimes it takes a little bit. So we have to be proactive. This isn't a patient we want straining to poo. So early on, we're thinking, let's give them something. And even if they say, my bowels are too loose, I don't like this, they can't be straining. You know, it's better they're having the impetus to go more often than they're not going. And then we're having trouble with, they don't want enemas. We don't want to have to do enemas on a patient like this. So be very careful. Okay, no heavy lifting. Men oftentimes have sexual dysfunction related to this. And again, it's because when the main vessels were clamped, we're relying on collateral circulation. And male genitalia, the circulation is very, very tiny vessels. So they can be impacted by this. Doctors will talk to them about how much time to wait and how long they think before they can look into other adjunctive treatments, but this will be something they'll talk to you about. And the doctors talk to them about before surgery. So what are the reportable symptoms they need to be telling their doctor? They need to talk about redness or swelling at the site, whether it's the abdomen or the groin, fever over 100. You know, they're going to have this inflammatory process going on while the body's healing. So they might have 99s, but over 100, And change in color or temperature of the extremities. These people have probably never examined their extremities for color or temperature. So this is a new thing we're telling them. And it's not just looking down and saying, oh yeah, my feet are there. They need to really be feeling their feet and see that they're warm. Do they feel they're warm? Do they feel their feet are always cold? And what are their pulses? Now, we teach them to take peripheral pulse. We don't expect them to do it, because what are they going to do that? They're going to bend themselves in half to reach down to their foot. They're impeding circulation. They could diminish their own pulse doing that. Somebody else has to be checking the pedal pulse for them. So we want to teach whoever it is they live with or whoever will be a supplemental caregiver when they're home. Okay, so aortic dissections. Now you've heard about this some, And every time I say it's not an aortic aneurysm, and it's not. But people always say, oh yeah, what does he have? A dissection, an aneurysm? Yeah. No. They're all very different. And so don't get into that trap that you get to a point, you'll feel the cold breeze that Jane's haunting you if you get to that point that you get sloppy like that. I always tell my students, all of a sudden you'll be cutting a corner and there'll be a cold breeze comes by and you'll know it's me. So aortic dissections. Here, we have a false lumen. You know, you have several lumens to your arteries. You know, you have your interna that's on the inside, you have the media, you have the tunic on the outside. So what happens here is an interruption on that inside layer, and it's going to divert blood flow between the lumen of the vessel. Not good. You divert blood flow like that, you're going to decrease your cardiac output. And here we are back to not sending blood to the brain adequately, not perfusing the body adequately, not getting enough blood out of the heart into the ostia. I mean, it's fraught with problems. So if it's a type A, it's usually the ascending and the arch itself. If it's a type B, it's descending from the aortic arch. So they classify them as they're either acute or they're subacute or they're chronic. If you have a chronic one, you had a dissection, it thrombosed on its own, and it's still there, but it's not growing. And you're more than 90 days out. You're a couple of months out and you're still fine. Wouldn't be the thing you'd want to walk around with. You're always going to have that fear. I would always have that fear it's going to open up again. But, you know, some of them self-thrombose on their own and stop. The acute ones are happening right now, and the patient is very acute, and we usually have to go in and act on it. The subacute, it's probably how many days out from some kind of procedure, and we're picking up, you know, something's changed with the patient or whatever, a couple of weeks out, and they go looking and scanning and doing everything else and realize, okay, there's something going on here, but it doesn't seem to be growing anymore. Still not a good sign that it happened at all. So 2/3 of them, unfortunately, are the worst variety, that they are acute and they're ascending. So they're going from the heart up to the aortic arch. Chronics are mostly descending. And I have seen patients that have had a chronic one that thrombosed, and it was like that. And they'd say, oh yeah, they found that 5 years ago. And that's good. They're still here talking and they've not had any issue, you know, can happen. Okay. So what causes it? Trauma, vascular disease. So we've gone up with the IABP, maybe. We're doing some vessel repair in your heart, and we've gone in with a line, and we've nicked something somewhere. They're doing a cardiac cath, and they're putting dye into your vessels, and the vessels don't have much give to them. And the catheter, as it's going through to do the stent, ruptures the vessel a little, and now the blood is dripping out. We have or it nicks it a little, and now we have a dissection. So it can be any of the above. It can also be the blunt traumas again. So someone falls, you know, gets thrown out of a car, you know, all these trauma patients I had, they're like flashbacks. You know, they fall off a building, some blunt trauma to the chest, and they survive it. But the shearing injury they have is that they've, instead of having this damage that's caused an aneurysm over time, it's just split the layers a little, and now we have a dissection. So each heartbeat, as the blood's coming out of the ventricle, it should go up that aorta and carry it to the brain and out to the body, and all the tissues are happy. But as it's going up, some of it will divert down that false lumen, and only some will get out. So that's the problem. So blood is getting depleted from somewhere. Sometimes it's all over the body, a little bit of blood is depleted. Sometimes it's the limbs, your feet, because they're the furthest away. So whatever blood is getting there is oxygenated, but there's less of it. Sometimes it could be the head, and you'll notice your patient is suddenly confused, and you know it's getting diverted down the aorta and down the false lumen, but not much up to the brain. So it just depends on the symptoms your patient's exhibiting. All right, so what are the demographics? Well, again, it's more men than women, and it's older men, 60 to 70 typically. Family history, vascular disease. That's the thing that underlies all of these issues, vascular disease. Trauma, the physician trauma, accidental trauma, assault trauma, any of that. Cocaine, you know, methamphetamines do it too. We see it from that because they make the vessels irritated and inflamed, and continuous use can do that. Heart surgery. We've gone in and we've done things and we might have nicked something somewhere. The pregnancies, again, are not a single pregnancy. It's not even twins. It's probably the people that have 6 or 7 babies that just puts a lot of tension and pressure on the vascular system. So dissection, they say, if you're less than 40 years old, it's probably Marfan's. And they would have known that by now, because Marfan's, you grow exceedingly tall and large and big boned and long limbs. And, you know, it's connective tissue disorder, but it's genetically filtered so that people are tested for it. So they would know if you had it in your home, in your family. All right, so here's our graphic. And here is your blood flow coming up your aorta and coming down your aorta, but there's a tear here. So it's over on this side. So it's almost a B because it's coming down. But anyway, there's a tear in the aorta. So some blood will come down and some will go down this false lumen. Now, it switches sides here because this picture is from this section. And the way this dissection is going around the back. And it tends to do that because it's a cylindrical shaped organ. You know, this aorta is round. So it tends to just go wherever the path of the fluid will take it. So here you can see, look at how much is down the false lumen and how little is getting down into the body. So this is a serious thing when people have this. You'll see it, your patient gets bad quick. Okay, and here's a great video that unfortunately we can't watch, but please put this into your search engine and watch it. And some of them are very simple. Some are just sample videos, so you see sample use on them, but it's the concepts that they're showing you. It's the process they're showing you that's good. Okay, so what do you see? Well, if it's ascending, they have sudden onset of pain. Of course, because your heart, your ostia are waiting for blood to feed the heart muscle. Your brain is waiting for blood. All of a sudden, they're like, oh, so you think is your patient having a heart attack? Could be. If the blood isn't getting to the surface of the muscle of the heart, it could be. But it's probably the causative agent is a dissection, only we don't know that yet. So descending aortas have pain in the legs and in the back. Which way is the blood flowing? It's going downward. So they can have it real bad in their back because that's where your aorta travels and that's where the false lumen will be. So they'll have this sudden aching back pain. But I've seen people that sit and rub their thighs or they pick their hand up and keep touching their thighs. And I comment on the behavior and they're like, I don't know what's in there. They want to know if there's still bone there. And the pain is so bad in their legs, they don't know what to make of it. And they're just rubbing their thighs and keep feeling them. And I'm thinking, okay, this is not a good assessment factor I'm finding here. And you have to start acting on it. I mean, what procedure has this patient had that would put them at risk for dissection? What's in their history that would put them, you got to put the pictures together so that you can call a physician and say, here's what I'm seeing. And, so it's stabbing pain. It's very sharp. They're very uncomfortable. So if it's in the aortic arch, you have to watch of all the things. The blood is not getting to the brain. You're going to see changes in level of consciousness. And by that, we mean everything from irritability to, a change in level of consciousness can be affective change even. Suddenly they're irritable and restless and they could be confused. They could be, it ranges however your brain is going to respond to this lack of oxygenated blood. So you're going to see that. The pulses in the carotids are what you see gets weak. That's what you see gets weak. So if you've been assessing your patient, and this is a vascular patient, you've been checking carotids, just because you're checking for JVD, you're checking heart sounds. I always check carotids on vascular people. And you'll find they're weaker and weaker. Why is there less blood flow up here? Why is my carotid pulse less? And that should tell you there's not enough blood behind it, giving you a good carotid pulse. That's really indicative. That's a big thing. So you'll notice another murmur because the heart now is going to try and compensate. They complain of chest pain still, and it'll seem anginal, and it most likely is anginal. You're not getting enough blood to the surface of the muscle. And they'll have, before you know it, if they're not perfusing, and you start seeing signs of shock right in front of you. They go bad pretty quickly, pretty quickly. So, and it's all over. It's blood everywhere in the body is not getting where it needs to be. So it's the whole body. All right, so complications, cardiac tamponade. Remember tamponade? Yes. So if blood is leaking into the pericardial sac, you're going to have a tamponade. So if the damage that was done doing this procedure, that people always act like it's nothing that someone's back from a cardiac cath, you have to think of what they've done. What's the concept behind what they did? It will help you foresee what it is could go wrong. So they went down for this cardiac cath, and as they're putting the guide wire through and they're putting the dye and whatever else they're doing, if they nick something, you have a problem. If it's nicked to the point that as it gets bigger, now it's seeping, now you're going to have blood in the pericardial sac. So we have diverted blood, and we could have some dripping in the pericardial sac. So what happens? They have JVD. Every heartbeat that's coming is bringing blood in. Can the blood get where it's going? Not so much. The body's going to try and help you and speed up that heart rate. And what is that doing? Is starting to show you JVD. JVD, blood isn't going where it needs to go. Your heart sounds with pericarditis and tamponade is going to be, as tamponade progresses, they get more muffled. You have to know what your assessment was prior. You know, when we first take students into clinical at any level, but hopefully the first time they introduce you, they always tell you, get your assessments done early. And in the beginning, it's hard to get your time management together. You know, we're all works in progress. It's hard. And, you know, students are trying to get their stuff together. And I'm always saying to them, get your assessment done early. If your patient changes in an hour, the first thing someone's going to say to you is, were they like this an hour ago? You have to have something to compare it to. So pay attention to the data you get off of this patient. So when you start seeing now muffled heart sounds, were they this muffled? You know, I tell you, stethoscopes are meant to go against skin. Listen to skin. And they shouldn't be muffled if you're right on the skin. It's not like you're listening through their night clothes and their sweater they've on because they're frozen and their bathrobe that's over that. Can't hear anything. You know, well, I don't want to disturb them. I hate to go down people's shirts. It's our job. You have to go in there and assess what's going on. So, you know, all of these things come back to play, and you realize you have to have something to compare it to. Okay, if there's aortic rupture from this, which there can be, it dissects and dissects as the pressure builds up, it can just blow. The whole false lumen just opens up. It's exsanguination. It's just like an aneurysm opening up. You have immediate no blood supply to the spinal cord, to the head, to the organs, anywhere, boom, patient's dead. And there's nothing we can do to get in there and do anything about it. Diagnostics, they can do a chest x-ray, they can. It'll show them a little shadowing. They're probably looking at the heart more than the vessels. They can do, excuse me, CTs or MRIs. They can do a transesophageal echo and see if that's going to show them something off of the aorta. That's helpful. It depends on the time we have, you know, how critical this patient is, how fast this dissection is spreading. I mean, it's problematic. So they can do an EVAR, but can we get to you in time? We have to know it's there. We have to go in and say, all right, we got to do something about this. Can we get them up? Are they a candidate? How else are they stable-wise to see if they can do this? And they can take them down and try and do an EVAR, see what they can do. Okay, interprofessional care. Conservatively, what are we doing? Well, the patient's in the ICU, and we're watching them. We're assessing them all the time. So if they have no complications from a dissection, like who is that purple zebra, unicorn, I don't know, but if they have no complications, then what we're trying to do is control the blood pressure. This is theory we're presenting, you know, control the blood pressure, control the heart rate. Let's not let the heart rate get high and the BP get high, that it's going to start that dissection again. Calcium channel blockers, if they don't want to give them beta blockers, if your patient's asthmatic or, you know, has uncompensated heart failure or something and they don't want to give them beta blockers, they might go to calcium channels. Morphine again comes into play, your morphine sulfate. And It's going to decrease some sympathetic nerve response. We know that, some stimulation, but it also relieves pain and the work of breathing. So if this patient, rather than have them riled and they have pain from this dissection, wherever it is, and you know, they're struggling to stay calm, and we keep saying, keep yourself calm, take a deep breath, and this and that, they may say, just give them a little morphine, because it does decrease the work of breathing. It will help them. Okay, so what else? Interprofessional care, a T-bar. We can do for thoracic aneurysms that are type Bs, so they're headed on the way down, that are complicated, which most of them are. They're going to try and do this T-bar. And it's similar to your EVAR, only it's higher up, and it's for your descending. They have to put lumbar drains in. Remember where we're talking. The aorta is post-peritoneal. So it's back, along the back. They have to move the organs and move everything and get under there. So where you're going to collect, if you're working on a thoracic aneurysm, you're going to collect fluid against the spine, and that can paralyze people. So they put drains in for that, lumbar drains, to collect that. All right, so if you have a lumbar drain, you have another access to infection. You have to have impeccable technique. I'm telling you, the cold breeze will come out of nowhere. It's me. Don't cut corners on this stuff. That's all they need now is a meningitis, because we're cross-contaminating this drain. And I know people think about, oh, another drain. It's not another drain. Where's it going? It's in the lumbar spine. I mean, you know, think about this. So you got to be careful. You're going to decide the kind of nurse you're going to be. And that's how all of us differ, you know? So open surgery. If it's a type A dissection, it's a surgical emergency. And they're going to hope they get in there before it keeps going on and on and on, and they can do something. So the mortality rate, you can imagine, is very high. On top of you having this dissection on your aorta and it's emergent, we're now having to put you under, which changes your blood pressure, get you in this state, cut your chest open it up, pop your lung, put some chest tubes in. I mean, this is not an easy process. And it's not to say they don't know how to mechanically do it. It's trying to keep you stable in the process. So it's not, it's the first line therapy if you have an ascending. They have to get in there and do something. So let's see, what else? For the chronic dissections, I'm telling you, if you have connective tissue disorder and all of that, they're going to try and be preemptive. So they'll just go in there and do something. The risk of your rupture is going to raise your mortality significantly. And you figure once they get in there and they're trying to do this open, they have to clamp you, they have to go in, take all these clots out, try and get rid of all this, repair the vessel, which can re-rip and give you another dissection down the road. I mean, it's not a simple thing. They will try, they always try. And if it buys you some time and you do well, that's great, but they're always going to give you the shot. So other causes of death could be the strokes you have, the MODS you have, or God forbid, the sepsis you get. You know, hopefully that's not at our hands that you're getting that. You know, I've had people that have come in all shut up with guns and have all these other things and these other problems, compounding things. Their risk of exposed infection is clearly multifaceted. It's not just caregiver, but when it's at the hand of caregivers, it's just really hard to see. Okay, so post-op, what are you going to do? Bed rest? I know it's not often we don't want people up and moving, right? Oh, this person, we need to have them chill a little bit. So they're in semi-fowlers. That usually helps them. They'll have meds as ordered for pain and anxiety. Some people think snowing them with opioids is the way to go and it covers everything. No, if they're anxious, they need something. The receptors are different. Your gamma and mu receptors in your brain for pain are different than your anxiety. So if they have an anti-anxiolytic, give it to them. This is a horrible thing they're going through, and it's a misery to be living through, and they feel very vulnerable. If they can't handle it and they're anxious, let's help them. That's what we do. It's a small thing we can do. All right, so vital signs, neurosigns, don't forget color, sensation, movement of your extremities. If they're throwing these little microclots, if they've thrown big clots, if the collateral circulation wasn't enough through surgery, you're going to see it in your periphery first, that they're going to start having discolored skin and lack of pulses and things. So watch that. Discharge teaching, They have to comply with the meds. I wasn't on meds before. You are now. And here's why you have to be good about taking them. Then you have to teach somebody who lives with them or somebody who's their support system. So they get this reinforced. They have to take their meds. They have to learn how to monitor their BP and their heart rate. That's important. The doctor will order them follow up, either an MRI, CT, whatever the doctor wants. And the leading cause of death is the redissection I talked about at the repair site. So they're trying to repair that vessel and do that EVAR, and it can rip open again. We've done now a surgical repair, and anastomotic sites can always cause us problems. So just because they went all through that doesn't mean it's not going to happen again. Okay. All right. That brings you to your last slide. You are done lecture in 202. How excited are you?
Very.
I was going to say, you don't sound very excited. I'm glad for you. We know this course is hard, guys. We know it's hard. We know that it's a lot of work. It's a lot of material.